Good morning, everyone. My name is David Anderson. I'm speaking to you from my home here in Brockham, just south of London. And welcome to the second day of the 5th International Forum on Cardiology and Cardiac Surgery for Paediatric and Adult Congenital Heart Disease. We have an interesting session this morning dealing with neonatal cardiac disease, and I'll just share a few thoughts of my own. The question really we're addressing is whether they should be managed surgically or interventionally. And I've been in the game for quite a while, and the saying is what goes around comes around. In other words, things sometimes come back again. So just looking at critical aortic stenosis, the early days, it was open aortic valvotomy, either on bypass, using inflow occlusion with hyperoxygenation and be as quick as you can, or transventricular dilatation off bypass. But no matter what technique was used, when looking at neonates, i.e. those that were under 1 month, a report in 1974 showed that out of 10 babies, 3 died before the operation of metabolic acidosis, 5 died intraoperatively, 1 postoperatively, and there was a single survivor, so a pretty depressing picture. And throughout the 70s, publications by Keane and Edmonds showed that the results were still very disappointing. And Edmonds, looking at 14 cases less than a month old, 7, i.e. 50% of them died. But Trinkle wrote describing transventricular treatment, and 4 of 4 less than 5 weeks old all survived the operation. And so the message that really came across from that in the 70s and 80s was that cardiopulmonary bypass was bad for infants and especially neonates. And so if it could be avoided, that was desirable. So in the mid-70s, Grunsek introduced the concept of angioplasty first to the femoral artery and then translated it to cardiac defects. And that was taken up by Lababidi, who first used the technique in a coarctation and then in an aortic valve in an 8-year-old. Encouraged by the results, he published 23 patients aged 2 to 17 years, all with very good results and very low mortality, in fact, none, I think. And that further encouraged to attempt the procedure in neonates, and published in 1986. And the technique was also deployed intraoperatively, deploying the balloon under direct vision with good success. But whilst this was going on, Carl, me, Braun, and colleagues in Melbourne were showing that with good surgical technique and with the more modern equipment, that 9 out of 9 with isolated aortic stenosis survived the operation. But if there were additional cardiac defects, it was still a relatively poor outcome. And Turley published a series from 3 centers of 35 cases surviving out of 40 neonatal surgical aortic valvotomies. Now, looking at pulmonary stenosis, which preceded aortic valvotomy by Brock and Holmes-Sellers in 1948, and we all recognize that prostaglandin has really made a difference. And balloon valvuloplasty is now a well-established therapy, and surgery in the neonatal period is rarely needed. And persistent arterial ducts, those that we are called upon to operate, are almost all preterm with low birth weight. Surgical ligation is well established. The operation can indeed be done on the neonatal unit where it's appropriately equipped. And percutaneous occlusion is well established for those with normal birth weight. But the question really that will be addressed this morning is percutaneous occlusion better or justified in the context of extreme low birth weight or prematurity? And turning to neuroprotection during arch reconstruction, the various techniques are deep hypothermic circulatory arrest and to operate as quickly as possible, or to deploy continuous cerebral perfusion at moderate hypothermia, intermittent flow or no flow at moderate hypothermia, and probably only really applicable to larger children and adults, is retrograde cerebral perfusion via the superior vena cava. But really the issue is that mortality in modern neonatal cardiac surgery is so low that morbidity, especially neurodevelopmental delay, excuse me, has become the object for improvement. So where are we in 2021? Well, the fact is that modern cardiopulmonary bypass has now been purpose designed for neonates and infants, reducing surgical morbidity and mortality. And prostaglandin has enabled metabolic resuscitation before interventions. And I have to say, given the surgeons a full night's sleep, that they operate, if they have to, in better condition. Diagnostics are vastly improved, and cardiac catheter as a diagnostic tool is now almost redundant. So that patients go to surgery in good condition, which must reflect on the outcomes. And for aortic stenosis, reports differ, some showing superiority of surgical aortic valvotomy, while others show that balloon aortic valvotomy may be better. So now is our opportunity to sort it out. And with that, I'd like to introduce our first speaker,